we had some inspiring stories on how successful the Downs babies can be. And looking at all that, we realize that it's not just about diagnosing, just not just about screening for it. It's also about a commitment that we have an inclusive approach. And we really know that, yes, a lot of these babies can definitely have a meaningful life. And that kind of an inclusiveness is something that we, as doctors or maybe as specialists, we are the ones who are actually picking up. So that aspect of that of Down syndrome also should be a part of our thought process. So today we've got, we're going to have Ms. Shanti Olak, who's going to take us through the psychological aspect related to Down syndrome. And then, yes, for us, it's always been screening, and screening for Downs. And that is something we've realized that, if you don't upgrade yourself for 6 months, you fall back by a year. That's the kind of, advancement that's happening as far as screening for Downs is concerned. And you would find that the cutoffs keep changing. So how far have we reached, with the Indian perspective, and how far, because the Society of Fetal Medicine has really put in years together to create this awareness for Down syndrome screening, and screening in the correct way. It's always been not just about, doing anything or just taking an NT and leaving it. We've really created that kind of an awareness throughout the country that screening, like I always say, if you do it well, otherwise don't do it at all. And so we'll have Dr. Ashok Khurana, our mentor, who will take us through how far we have reached. And so welcome you all again. And I request Rima to introduce Ms. Shanti, and then let's take the program forward.
Thank you, Vimal sir. We, on behalf of Society of Fetal Medicine, we extend a very warm welcome to Dr. Shanti Olak. Introducing her, she's the chairperson and one of the founding members of Muskan, an NGO formed by parents and professionals in 1982, provide needed services for improving the quality of life of intellectually challenged children and adults, and emotional and knowledge support to parents. Dr. Olak has been coordinating various services that the association has been rendering to intellectually challenged children and adults and parents and families. Muskan has been awarded various awards by the government and corporate sector, including National Award by the Government of India. Dr. Olak has been honored with several awards: Women Entrepreneur Award, NDIM Management Award, Interville Social Impact Award, and Disability Commissioner Award for invaluable contribution to the field of intellectual disability. We would also like to mention that Dr. Olak was teaching in Department of Psychology, Lady Shri Ram College, Delhi University. She took an early retirement to devote all her time to Muskan. We welcome you, ma'am, and we would want you to take us through the psychosocial perspective of a baby when a parents have baby with Down syndrome. Thank you.
Thank you so much, Dr. Rima, for organizing it and giving me an opportunity to share some of my very deep experiences of working with people with Down syndrome, as well as other forms of intellectual disability. I would like to share that we started in 1982, when we started our society. We started it as welfare association for Down syndrome children. But we realized soon after, in a few years, that there are so many other reasons also for disability, intellectual disability. So we expanded to include Down syndrome as well as the other forms of intellectual disability. So there are hundreds of young people who have received training in Muskan, And Muskan does not only limit itself to training, because that doesn't mean anything unless you create an employment opportunity. And that is what has been an extremely, I would say, happy experience, successful experience for us. Very briefly, I would like to say why um, Down Syndrome Day is being celebrated. See, when I look at many other such days, whether it is Mother's Day or it is Yoga Day and so many others, all these are to remind us, to make us aware that there are people who are adding a lot of value to the society, and their contribution is, or even understanding about them is very, very limited. So in the wisdom, humanity has decided to have this as a day. My introduction is incomplete unless I share with you that my son, the second child, he uh, he has Down syndrome, and I got to know 2 days after his birth. So it has been I would say it has been an amazing learning experience for me, bringing him up. And being a psychologist, I could understand many things about it. I learned many things by working with him on various aspects of development. And then I realized I should share all those learnings with other parents for other children also. So that is how Muskan was started. What I have seen, a few things that I would like to share. Normally, somehow it happens when a child has intellectual disability or any other form of disability also, we are not able to see many other aspects of their personality, and we remain very focused on the disability rather than the person who has that kind of a situation. And I realized that except for cognitive aspects of development, children with Down syndrome have all other children with Down syndrome, as well as, just a second, sorry, as well as other forms of disability, their emotional development, their social development follows exactly the same pattern, same stages, same unfoldment of various kind of potentials. It happens exactly the same way. And I realized that those aspects are never into focus. As a result, we create so many emotional difficulties for them. So cognitive aspects also, the higher intellectual functions where there is a difficulty, but then there are so many other you see, aspects of development. If we focus on it, they really grow very, very, very well. So much so that what I realized is that the strengths that people with Down syndrome and other forms of disability they possess, they are such diligent worker, very focused, very structured, responsible, and at the same time, the emotionally, socially, their capacity for love, unconditional love, their capacity for happiness, their capacity for care and responsibility is so touching that you realize how good human beings they are. So, you see, personally, I would say that I really felt over the years that so much injustice is being done with people with Down syndrome. And with the current diagnostic methods which are there, I was apprehending that many children, because of the misnotions which are there, they may not be able to kind of grow and come into existence, because somehow the society has developed an image about them that you feel that there's no point in persisting or in continuing with such pregnancy where we are going to have a child with this kind of difficulties. I tell you, when my son was born, of course, I was extremely perturbed by it. But when I started looking that why I am grieving over a new life, which has got a chance to live and enjoy this beautiful world, why should I be grieving? I should be helping my baby to grow up as much as he can, and provide support and let him have his own ways of enjoying this world. The kind of grief I had in the initial period when I came to know, and today when I compare my feelings, and I'm truly sharing my sentiments with you, that I find he is the biggest blessing in my life. He's such a nice person, so responsible, caring, happy, living in now all the time, and always ready to learn, always ready to do and take on responsibility. And I feel often I take my lessons for my life from observing his behavior, observing his work, and so on. So it really, it creates an existential question in my mind, that how our utilitarian attitude is putting us into a certain kind of framework where we stop valuing the people with diverse kind of temperament, diverse kind of ability. And we are so hooked on to achievements, we are so hooked on to competition, that we fail to see the beauty of every form of diversity which happens, which nature provides us. I would also like to share with you another story. Around 10, 12 years back, a girl called Kajal, who used to live, she had intellectual disability, mild intellectual disability, and she was living in an orphanage where she was sexually abused by the caretaker, and this girl got pregnant. The home people, the orphanage people, went to the court and said that this girl cannot look after a baby, so the child should be aborted. Anyhow, another lawyer of Supreme Court, and this judgment was given by Punjab High Court. She took the case to Supreme Court, and at that stage, Muskan also joined, and we argued along with this lawyer that if this girl is provided the necessary training and support, she would be able to look after her baby, and that girl also wanted to have the baby, and moreover, this girl was abandoned by her parents because she had intellectual disability. I mean, the whole scenario. And we took the Muskan took the responsibility of providing that training. to this girl, and she used to live in Chandigarh. We have made there those kind of arrangements. And today, she has a teenage daughter who is studying in a school, and how much the life of Kajal has got enriched in the process. It really fills my heart with, I would say, so much compassion, so much value for people who are not understood, whose needs are not understood, whose humanness is not understood. And we take all kinds of judgments and decisions and distorted notions about it. So I would say that since this is a Down syndrome day, I would say children with Down syndrome, adults with Down syndrome, the senior people with Down syndrome, it's a pleasure to have them around, and they bring so much humanism in the society. They have the capacity to bring that. And what we find is that whoever, the Muskan, very many people from the community have associated with Muskan, and they are providing support. They are actually supporting us with infrastructure support and with financial support for us to be able to carry on our work. And they get so much touched by the humanity which our children are able to carry with themselves all the time. So talking to you is I would say, has been a dream to me, that how much what we think about them and what they really are. And we need to change our thinking about it and allow nature to have a diversity of all kinds, so that everybody learns from each other, everybody supports from each other. We are living with support only, the whole infancy and childhood, and then old age. So who is completely independent or self-reliant? So those people who need a little bit of more support, nothing wrong in it. It's absolutely healthy situation, normal situation. So my life has been transformed by working with them. And I am full of gratitude to all these children for making me see those sensitivities which we all need for each other. Thank you, Samir, so much.
Thank you so much, ma'am. I think you've really touched our hearts, and your each word has touched us deep down. And our respect for babies with Down syndrome has definitely increased. We really thank you on behalf of Dr. Ashok Khurana and the entire team of SFM to be with us today. Our next talk is by Dr. Ashok Khurana himself. He's the father of fetal medicine who advocates in us that we need to screen, but we don't really need to terminate all babies of Down syndrome. So I would request Dr. Khurana to take us through screening for Downs. Where are we today? Thank you.
Thank you, and thank you, Shantiji, for taking us forward in our mission to open people's minds to fetal needs and for those with special needs. We do need to do a lot of rethinking. We are tuned very strangely in this day and age, and we seem to accept what we are told without questioning it, unlike the other things we do. And I'm so glad you have shown us the path. We now take this evening further forward on this special occasion of the Down Syndrome Day. And I will go ahead and talk about where we stand with our Down syndrome screening and what we need to do as we go forward from here. So over the next 20 minutes, and thank you, Galrima, for putting all of this together, I will discuss where we are in screening for Downs. And I will take you through what has emerged as the theme for this year's Down Syndrome Day of ending the stereotype. We must question every step of ours. We know that there is a world beyond screening for Down syndrome. We know that there is a world beyond technology, and that is the real world. And I'll try and fit that into the right perspective of how we should face this whole situation. For those who are not with a scientific background joining us this evening, you know, of course, that Down syndrome occurs when a person is 3 rather than 2 copies of chromosome 21. It is the most common congenital cause of mental disability and can lead to considerable ill health, although some individuals have only mild problems and can lead relatively normal lives. There is unfortunately, however, no current known cure for Down syndrome, and having a baby with Down syndrome is likely to have a significant impact on family life. Not because of the baby who has Down syndrome, but because social and individual sensitivity are tragically very rare today. Social and psychological acceptance and social support remain very rare value in today's world, rather than what we used to see in my growing up years, where social support was the essence of civilized society. In addition to that, training and educational facilities are largely suboptimal in most parts of the developing world. And that puts us in a new spot, because then what we end up doing is changing our entire perspective on this whole situation and pushing a significant number of parents to opt for terminating such a pregnancy. Now, within the actual profession, this is not the easiest thing to do, because it does amount to, as one of our members said in one of our meetings a few weeks ago, hunting them down and killing them. But the fact is that there would be others who would benefit from preparing for such a baby. And even these ones where we identified and they feel for themselves, then perhaps we have to respect their right to figure out whether we give them this option or not. And the world seems to also be moving in this direction, that give them the option and let the individual decide what they wish to do, given the perspective that modern society has evolved to. The good news, of course, is that Down syndrome can be suspected and diagnosed during pregnancy. The formal scientific protocol that is used to suspect Down syndrome in a pregnancy is referred to as screening. And tests that actually yield a confirmation of Down syndrome are called diagnostic tests. So biochemistry, ultrasound, and NIPT are all screening tests, and procedures such as CVS or amniocentesis, which yield material for sending to the lab, will then result in a QFPCR of fish, karyotype, or an exome to confirm that particular diagnosis. So I will take you through a relevant perspective of aneuploidies evaluation from a screening point of view. I won't discuss the how-to, because that's quite an exercise different from what we're discussing today, but a real-world approach when it comes to the first and second trimester aneuploidies screening. And let's start right at the beginning, at what I refer to as first things first, and that is pre-test counseling and considerations. Please do remember that the end point of evaluation for many conditions is termination of pregnancy, where parents would not want to carry on. This can be either because they feel that it's too much to handle for themselves, or the fact that society doesn't support them. But we're not here to find out why that happens. Now, in this part of the webinar, I want to devote some time to letting you know how best to yield the best results for this group, so that we can give them the options, pretty much what we do in various other conditions, because there will be someone who will not terminate the pregnancy, and therefore we must also let them know that, yes, in that case, come back and we will do a good scan for you between 20 and 22 weeks of pregnancy. Now, evaluation for Down syndrome involves screening. Screening means the identification of those mothers that need further evaluation for the diagnosis. By definition, therefore, screening will not identify all affected fetuses, and this must be brought out in the pre-test counseling. And screening can also yield false positives, which means a test which is positive saying that the baby might have the disease, but the baby does not have that particular condition. When I say disease, I refer to a greater perspective. Some people think of Down syndrome as a disease, and some think of it as a variant in nature, which we can happily survive with. And I fall into that category too. Now, pre-test counseling does take time, energy, lots of personal and expertise, and of course the cost associated with it. And these tests are usually paid for by the patient in our part of the world, and hopefully that will change in the near future. Now, when we start right at this point of what we're supposed to do next, we realize that things have evolved. We started with just maternal age in the early 80s, which told us that we will identify Down syndrome. But we realized soon that that identifies only 30%, because only 30% of Down syndrome babies will be born to mothers who are more than 35 years old, because they're not so active in terms of reproduction. We then found low levels of alpha-fetoprotein in 1984, went on to high levels of HCG, which we then combined for the triple test, the second trimester triple test, and then improved it to the second trimester quadruple test. And then in the 90s, Kypros Nicolaides taught us that we can combine PAPE, free beta HCG, various maternal parameters and characteristics, along with a good nuchal translucency scan, and give a combined risk. And that is something that we have now evolved into giving people information. Now, why do these change? These simply change because the sensitivity has changed. The triple test identified only 65%, and that was not enough. The second trimester quadruple about 75, and that was just about borderline because 75 is our cutoff. The first trimester combined is very nice, about 90%. But the cell-free fetal DNA, the new one, well, I shouldn't call it new because it came in 2011. That's when Society of Fetal Medicine first introduced it, actually has over a 99% detection rate. And therefore, these have continuously evolved. And let's see where we are today. We must also understand that it's not just trisomy 21 that we're able to locate, but also the 13 and 18, as well as Turner syndrome, triploidy, and the sex chromosomal aneuploidies, when we look at these particular conditions. In fact, we no longer use our 11 to 14 weeks window as a simple detection of Down syndrome or suspicion of Down syndrome window. We use it for dating to confirm number and viability, and then stratify risk for twins if necessary, and the care that we will take of them. We extend beyond the nuchal translucency to nasal bone, ductus venosus, and tricuspid regurgitation, and do a risk assessment. We also very, very importantly assess for structural defects. We screen for preeclampsia, and in the high-risk group, we do a cervical length assessment for screening for preterm delivery, not for all, but the high-risk group. And we look at maternal pelvic pathology, and that's the total picture because really speaking, Down syndrome is only 1 in 800 births, and the rest of the conditions account for much more of disease, and those are preventable, and you can do so much more for them in terms of patient options. We also understand that a lot of this search gives us inputs for cardiovascular disease, pulmonary defects, skeletal dysplasias, congenital infections, and hematological disorders, and therefore it has an added advantage. And this applies to other markers too, particularly the vascular markers, which is the ductus venosus and TR, and therefore they serve as very good inputs, and we feel happy using them. When non-invasive prenatal testing came along, it was realization of the fact that there is in the maternal circulation placental DNA, which is not within cells of the placenta, but free-floating DNA. And if we are able to process that in the lab, we will be able to identify those fetuses that have a high risk for trisomy 21. Again, something that needs to be confirmed by a diagnostic test. So in that particular situation, we thought, okay, that's the end of the first trimester ultrasound, and we were pretty happy. But that was not to be, because we do require a basic amount of this placental free DNA as what we refer to as fetal fraction, which means how much placental DNA compared to maternal DNA. And if that's not more than about 4%, then the results that we expect are not so reliable for the aneuploidies. And this depends on maternal habitus, and the heavier the weight, the less the fetal fraction. It depends on the duration of pregnancy, the number of fetuses, and whether the fetus is alive or not. And so as a consequence, we did need to get back to our first trimester scan, and today that's something that we just have to do. May I remind you again that the basic process initially is to identify by screening who needs a diagnostic test, but also that because of the 100% detection rate of an aneuploidy by an invasive procedure, it must be offered to every patient. We seem to forget this and we become judgmental and say, oh, why should we even offer this? The fact is that the risk of this procedure in experienced hands is no longer more than the general risk of a miscarriage for that particular patient. So if she has fibroids, she has the risk of fibroids, and it remains the same whether you do the procedure or you don't do the procedure. And therefore, we must offer this to every patient as the final thing. Not that it's done everywhere. Most of us would be judgmental and say, let's go step by step so we don't scare our patients. And in that case, we say, all right, let's see what happens. We do have a miscarriage rate. And if we were to accept a miscarriage rate of, say, 1 in 200, for instance, or 1 in 800, let me say that's the usual thing, it implies that if all pregnancies had an amniocentesis, 1 normal fetus would be lost for every 16 cases that are diagnosed, which is not acceptable. And also it leads to a lot of increased expenditure. And therefore, even in European countries, which are very well-to-do, the idea is first to do a screening procedure and then a diagnostic procedure where necessary. We must also remember that there are certain old tenets that are still true. That's where we still stand today. And that is that trisomy 13 and 18 have enough signs on ultrasound to tell us that, yes, this is the particular condition. And therefore, we will be able to identify it on the ultrasound, not just by the markers, but also by the presence of structural abnormalities. Structural abnormalities are not so common in trisomy 21, and we see it only in about half the patients. The markers may be more frequent, of course. And therefore, we have to work very hard on trisomy 21 to try and identify correctly which patients are yielding the right kind of screen. And ultrasound and biochemistry are the biomarkers that we use for screening. Now, the first trimester we've always known is better than the second, and that is still completely true, that the second trimester triple is definitely out of the window and never yields anything more than 65%, so completely unacceptable. And because of the poor quality control of the second trimester quadruple, we also don't encourage it as a basic screening test. Of course, it's the only possibility that we can have if the patient comes in the second trimester. And then, of course, we give them the option of an NIPT as well, or invasive testing. In the first trimester, using NT alone might also put you on the borderline of only 75%. And using biochemistry will never give you more than 70%, and that's unacceptable. What we have to do is to follow the conventional test called the combined test, where maternal age, maternal characteristics, NT, free beta HCG, and PAP-A will give you an 85 to 95% detection rate with a false positive rate of 5%, which is completely acceptable. If you add on additional ultrasound parameters of the nasal bone or tricuspid flow or ductus venosus flow, detection rate goes to 96%. Most importantly, the false positive rate falls, which really makes it very convenient for the patients to accept that, oh, okay, so this is an accurate test as they like to use in our part of the world. Please do remember that because we're also looking at structure, and the structure changes hugely from a crown rump length of 45 millimeters to a crown rump length of about 6.5 centimeters, it's ideal to really do these at 12.5 weeks. Some people argue that this low PAP-A that we see in trisomy 21 is far more pronounced at 10 weeks compared to 13 weeks, and therefore we should do biochemistry at 10 weeks. That is true. However, it becomes inconvenient for the patient, compliance is poor, and in most countries all over the world, the trend is to do everything once in one sitting at 12 and a half weeks of pregnancy, and we must try and do that at 12 and a half weeks of pregnancy, and then try and pick up all the structural stuff as well. There is, of course, this question on what's the hurry, and we'll find out anyway later, but that's not true. That a lot of the signs will disappear after 13 weeks plus. B, if we do find a problem, then if termination is the option, the first trimester termination is easier, safer, and psychologically much more easy to handle. Also, that there's an early reassurance to at-risk mothers, and we can end up dating a pregnancy. If you need advanced genetics for a particular clinical finding, ultrasound finding, then you have enough time to do so. And of course, you have the early intervention for the prevention of preeclampsia and preterm delivery. The next question is, should we do all of these as transabdominal scans, or should we do them as transvaginal scans? There's no doubt that structure is better seen with a transvaginal scan. And therefore, if you want to see anatomy, that's the way to do it. But you do require the fetus at a low transverse position. Also, it's much easier to manipulate a transabdominal transducer than a transvaginal transducer. Therefore, typically, you try and complete as much by a transabdominal scan, and at least the NT and the mid-sag view with a transabdominal scan. And then for further anatomy, you can go on for a transvaginal view. You have to follow the rules. And till today, there is no compromise on that. We are where we were before, that if you do this correctly and you have that true sagittal section with a crown rump length of 45 to 85, and you magnify it correctly and you leave enough space between the chin and the chest in terms of fetal position, then you will get the image correctly. And then, of course, the zooming must be absolutely right, and you turn down the gain for better results. We've also learned that none of this can be done without a good crown rump length. And you have to take a mean of 3 readings for the crown rump length. And then after you've assigned the date, of course, the next step is to actually interpret the whole story the way it has to go. The aneuploidies, of course, are always this concept of markers, risks, and cutoffs, because the findings of all of this are the same in normal and abnormal fetuses. We call them markers. When we put it together with the clinical pointers and the biochemistry, we get a risk. And then we use a cutoff, which is given as graphs or figures in the reports that we take. And the pointers that we use are the maternal age, maternal weight, ethnicity, IVF, the number of fetuses, diabetes, and smoking. And of course, if we add on additional parameters, we are in a very comfortable position to then screen correctly and get the answers absolutely as far as possible. Remember that there is no abnormal or normal nuchal translucency. It is always expressed as a centile. Yes, we have a wide range or a narrow range, if I may use the word. We used to use a figure of less than 3.5 being normal, because more than 3.5 often yields the highest yield for abnormality, but we don't use that anymore. What we do is we put this particular figure either into the algorithm of the Fetal Medicine Foundation or on perinatology.com, and you get the centile, and then you use that particular centile as a cutoff for that particular individual. So far, we've been using a 99th centile as a cutoff, but there was this absolutely fabulous paper just before COVID from Katerina Bilardo's group that told us that there's a fair amount of yield of abnormal fetuses when you use 95th to 99th centile for evaluation as well. And this paper was really path-breaking because it highlighted the fact that you could identify a large number of the rhizopathies as well as some of the other conditions. And therefore, 2 things happened after this. A, we started using 3 millimeters as a cutoff rather than 3.5. And we ended up identifying almost 23 to 24% of abnormal pregnancies, which were not more than the 99th centile in terms of NT, but between the 95th and the 99th. You know, this business of using lower cutoffs may be less cost effective, But if you give this option to patients, I have realized that most patients would actually opt for this kind of a situation and say, look, I think I will go ahead for invasive testing. But please remember that abnormal NT is not equal to Down syndrome, and you should never terminate a pregnancy, and this will never change. So we still stand where we were on this particular matter, that a pregnancy should never be terminated just because it's too much of a hassle to investigate that particular pregnancy. Also, that there is no association between a thick NT and the rest of the ultrasound parameters and biochemistry, and each is an individual parameter. Of course, there is no doubt that tricuspid regurgitation correlates a lot with thick NT, but ductus venosus does not. And therefore, ductus venosus is a fairly important individual parameter, and so is the low PAP-A. And therefore, we need to use both the biochemistry as well as the ultrasound to then do this. The risk groups have not changed, luckily, over the last 2 years. And this is the suggestion from Kypros Nicolaides. What he suggests is that if your risk is greater than 1 in 10, you offer invasive testing. Between 1 in 10 and 1 in 50, you give them the option of either a high pass screening, like an NIPT, or invasive testing. If there's a low risk, like 1 in 1,000 or 1 in 2,000 or 1 in 50,000, you just do a genetic sonogram at the time of your anomaly scan. But if it is between 1 in 50 and 1 in 999, and some people in India like to use 1 in 250 as this cutoff, 1 in 250 to 1 in 999, then you do the rest of the ultrasound parameters and you recalculate the risk and then tell the patient that you could have the option of another advanced screening test. But what most of us end up doing, and correctly so, is actually to offer invasive testing for a thick NT, because really that will yield the most efficient diagnosis. So currently, Kypros uses 1 in 50 as that cutoff, and most of India uses 1 in 250 for that kind of a cutoff. So what's an appropriate model that you and me need to use? And let's look at this chart in the next few minutes that I have. There's no doubt that for universal screening of the population, we use age, maternal parameters, crown rump length, nuchal translucency, PAP-A, and HCG, which is the famous combined test. There's no doubt that if it's only Down syndrome you're looking for, and you have the money, that crown rump length and NIPT is really a great option, but it is expensive compared to the routine, although it's become much cheaper now. Also, it misses the advantages of a first trimester scan of preeclampsia screening and structural screening. But if you combine crown rump length and a first trimester scan and NIPT, that's a great option. So what a lot of us are doing in private practice, for instance, is to do both. That means you do your first trimester scan and NIPT and PLGF, so you get to cover all these conditions quite appropriately. We've had some addition of biochemistry over the years. The alpha fetoprotein was added to sensitize us for neural tube defects, but it was really more ideal for people who were not good at ultrasound. But the first trimester penta, when in addition to the alpha fetoprotein, the dimeric inhibin A was added, has given us a 98.5% detection rate with a 1.3% false positive rate. So that really is a great screening test also to go by, and it is very, very inexpensive. A few words now on the second trimester screen, still relevant because some of our patients come in late. Also, there is that little tiny group that would say, look, I'm not happy with my first trimester screen. Can I do something else? And you said, well, it's not the most intelligent thing to do when you have a thick NT. Invasive testing is the best option. But from that group where you have just the abnormal biochemistry, you start wondering what to do. Was it from a good lab? Was it not from a good lab? Was the ultrasound a good one, not a perfect one? Then you could possibly offer them NIPT or a quadruple test while they make up their mind about an invasive procedure. This particular genetic sonogram is then done accordingly, depending on what you were suspecting, either at 14 or 16 or 17 weeks. And then you put all of that into the great Agatha Cleo's meta-analysis from 2013, work out the mathematics, and nothing has changed on that. And we are still exactly where we were 5 years ago. and you base your decision on the likelihood ratio of all of the positive and the negative. So what do we do now that NIPT is widely available? We know it has a high detection rate with a very, very low false positive rate, but it does fail sometimes. So therefore, I usually suggest both, and you could choose any. Also, the cost has limited its widespread use, but that is going down, down, and down as we go ahead. Several studies have suggested a contingent approach, which seems to work very well, which means you do your first trimester combined screen, and all of the high risk and the intermediate risk, you then push onto an NIPT and decide who falls into high risk and low risk on that basis. And that seems to work both in terms of economics and acceptability by the powers that be in government. And that tiered approach works. Meanwhile, what I normally suggest is that we should do a screening for aneuploidies and PLGF and get the preeclampsia done, because that seems to, of course, improve our screening, but most importantly, identifies a disease that is far more common and important. Remember that in India, we may not be able to do this in all our institutions because we don't have enough money, or the numbers are too many, and we don't have enough staff or enough equipment. In that case, every institution must make its own protocol and decide this accordingly. There's been no attempt so far by the government to financially support aneuploidy screening, but efforts are on, and with the hope that we are going to shift into the realm of public-private partnership with the next term of government, if it gets elected, then we may be working on a very firm footing of offering this to everybody. The basic minimum, meanwhile, should be NT plus PAPE plus beta HCG. The high incidence of preeclampsia in India warrants a need to add PLGF. Counseling, especially pre-test, but also post-test, is extremely important. It should, however, be non-directive. And you could have a community payment program where for a small insurance amount of between 600 to 800, the patient gets a free NIPT in case the first trimester screen is positive, and in case the NIPT is positive, you get a free QF-PCR on CVS or amnio. And thank you so much for your attention.
Thank you, sir, for the brilliant talk. I think everybody's been enlightened as to where we are as far as screening is concerned. We would now move on to our next part, that is the question and answer session.
Yes, and if I may interrupt, we also have an announcement from our Bengal chapter. And can we take a minute there?
Sure, sir.
So if, yes, Kanchan is there online, and I will highlight him. I want you to unmute this, and then after that, perhaps then Aparna can take on the questions, if that's okay with you.
Yes, sir, perfect. Yes.
Yeah. So the spotlight is on you, Kanchan.
Thank you so much, Dr. Khurana. So basically, it's our little endeavor from SFM Bengal chapter that we have taken on a couple of years back to publish our quarterly newsletter. And every time we take up a specific theme, this time, although it is not related to Down syndrome, this time the theme is actually Rh negative pregnancy, but we have chosen the very special day to release our newsletter, and it has quite a few topics across the issue, like rhesus negative pregnancies, what is the pathology, how do we care for these women, and all those sort of things. And I would be really grateful if our mentor emeritus, respected Dr. Ashok Khurana, and the national president of SFM, Dr. Bimal Shahani, could take a minute to release the issue for us. And then from tonight, we will release it. We will share it with all our SFM chapters. Sir.
Excellent. Bimal, can we go ahead and do this wonderful
Yes, sir. Yes, sir.
release? There we go. Wonderful. Congratulations, Kanchan, for bringing this out for us. Very, very nice.
And a very apt day to, bring this out on a very special day.
Thank you so much, Dr. Shahani. It is the combined efforts of my team members here in Bengal, especially Dr. Ananya Basu and Dr. Dipanjana Datta this time. But what is more important is the relentless support from our central team, the entire central team, and the Conferences International, which actually make it possible. It is not easy to publish something on a regular basis every quarter. And we have been able to bring the 6th issue in the last 2 years. Thank you all.
Marvelous, well done.
That definitely deserves the ovation, sir. Thank you so much. And I think all of us will benefit. I would now request Dr. Aparna to take on the question answer session. We would want you to post more questions on the chat box that she can take forward. So with your permission, we begin the question answer session.
Yes, please, of course.
A very good evening to all of you and respected sir, Dr. Bimal Sani sir, and Dr. Rima, all the participants here. And we are here to commemorate the Down Syndrome Day today. We had excellent talks from Dr. Bimal Sani sir and Dr. Khurana sir, who talked about the screening, where we are today. He brought out such important points. So as we move on, we have some very interesting questions which have been put on the chat. We can take them one by one. I think we will take the first question, which is if the Down syndrome has been detected late at 28 weeks, how can we go ahead? So, Dr. Khurana sir, would you take that question?
I presume what is being asked is if I find a condition where I might suspect a Down syndrome, such as a duodenal atresia, then what would I do next? Or should I try and exclude a atresia at this stage? The question is, you always lay the cards on the table. And you lay the cards on the table by saying that, look, we have a sign here. This baby can be born and we can treat it. And it can be handled by the neonatologist and by the pediatric surgeon. Or because there could be an underlying Down syndrome, what is it that you as a couple think about this? In that situation, we would like to do, in that case, invasive testing. They might have a slightly higher risk of a miscarriage because of the presence of a polyamnios, and we will counsel them about that. We do know that is most likely what is likely to yield a result, because these days we don't depend on cells, we depend on DNA within amniotic fluid. The patient might ask me, do you have something that is less dangerous? And I say, well, we could do an NIPT. The NIPT yield and the no call is not so brilliant at 28 weeks, but it is still reasonably reliable. And therefore that is one option. And this is what they have. Also, doing nothing is an option and just accepting the baby as it is.
Right. So I think great points. I think the thing is that we need to offer them testing, whether they go ahead, don't go ahead. They want to be mentally prepared for this. So I think that is something that we need to discuss with the patient and offer them the testing. So that is one thing, and that's what we want to talk about. So I think the next question, I think there are a lot of questions from Dr. Rahul Gera. So one is that the previous child with Downs, would you offer NIPT directly or contingent? So there are two questions here, but I think we take the first question first. Dr. Bimal, you are here. There's a previous child with Down syndrome. What test would you offer? How would you take this question?
See, first of all, it's very important that you know what type of Downs was it.
Yes.
Yeah, because we know that 98% of Downs are de novo as such. So that is one thing. Now, if it has been a translocation type, then definitely the chances of recurrence are high. And probably in most of these cases where the first child has a Downs, usually you would find that the anxiety in the parents is very, very high. And hence, a lot of parents would probably opt for a much either a very high screening test like NIPT or maybe invasive itself directly. So that option would remain with them. But otherwise, our routine screening. That's why if we have the report and we know that it's regular Downs, then we could also go ahead with our regular combined screening. But I've seen that most of the time parents would opt for a better screening test, and hence
Right, right.
a better thing.
Right. So I think NIPT or probably even a diagnostic testing if the patients, the parents wanted. Dr. Shanti, you've raised your hand. Would you like to comment?
Yeah, I know. I wanted to know, I have a curiosity that once the parent comes to know that the fetus has Down syndrome, how often it is you can find that they want to continue with the pregnancy. Does that happen? Or people want to get rid?
It does happen,
So,
ma'am.
ma'am,
Sometimes it's not a very common situation where they want to continue, but
Yeah.
it does happen when it's a very precious pregnancy, uh, maybe an IVF or a pregnancy which is occurred with ART, maybe the third or fourth cycle of IVF, and that is, but then it's a rare entity. Majority of the times they would actually like to terminate the pregnancy.
Ma'am, and I would agree with that. I work in a government setup, and in my experience, I would agree with what Dr. Bimal is saying that majority of the time, the parents would want to go ahead and terminate the pregnancy. From the reports that I have read, from the literature that I have reviewed, it has been seen that the parents of the babies who have Down syndrome, when they were actually asked that, in your next pregnancy, if you had a Down syndrome baby and going back, would you have actually, wanted to terminate this pregnancy? They say that probably no, we are okay having a Down syndrome baby. So that's something which is very, very different perspective from the parents who have, parented a Down syndrome baby. But first off, in my experience, most people go ahead and terminate the pregnancy.
Yes. Thank you.
Right. So I think going to the next question, and I think this is something that is a very pertinent question in the sense that, if you have a lady who's of advanced maternal age, which is more than 35 years, would you offer her NIPT or would you offer her a contingent screening? That means you would go for a biochemistry and then look at, whether she is having high risk and then offer her NIPT. Dr. Khurana, sir?
We offer every patient everything. We have no business to be judgmental. Our training is that, okay, I am the waiter at this particular restaurant. This is my menu. This is an international menu. This is it. This much you can get is the cost for this. This much is the result of this. Now you choose. It has to be a cafeteria approach. And we cannot say, oh, I think this might be this, or you're more likely to have this. There's no justification for that.
Right. Absolutely. I think that's a very nice way to put it. And the message is very clear that we need to tell the patients what are the tests and what are the detection rates of each of the tests and what is the cost factor for each of the tests. I would just like to add one point here that let's be careful when we offer biochemistry to women who are more than 35. We also should know that. Because, that those tests will come positive in 1 in 6 women just by virtue of their age, right? So we have to also know that. So essentially, so have those numbers also in mind when we offer the biochemistry in advanced maternal age. So we also need to know that. So but as sir said, we need to offer everybody everything and know the cost versus the detection rates of tests and let the parents choose. So thank you very much, sir, for that answer. So the next question is, again, we talk about ARSA with echogenic bowel, NIPT is normal. Dr. Rima, would you like to answer this question? ARSA with echogenic bowel, NIPT normal, what next?
Yeah,
Why
so
did we do NIPT?
Yeah, so when you have echogenic bowel, we are not only just looking at the chromosomes, there could be possibility of fetal infection, which is past vertical infection like the TORCH group, Toxoplasma, CMV, and we are looking at the possibility of some single gene disorders as well in this case. So when it's echogenic bowel with ARSA per se may not, nowadays we don't take it as an important marker for Down syndrome, but here NIPT would not be the solution. In this case, definitely we would like to advise our patient regarding invasive testing, because we are looking at just not the chromosome, but beyond the chromosomes as well.
Right. So I think the message is quite clear. I think, like Dr. Reema said, when we have structural markers, when we have other things, NIPT may not be the best option. Maybe the patient had NIPT earlier before all of these appeared. So that is the reason NIPT was done. NIPT should not be offered as a first option. All of this would require amniocentesis. Again, the same situation, CPC with, okay. Dr. Bimal, CPC with pelvic calic dilatation. NIPT is normal. What next?
See, one thing, now there is evidence and literature coming from the maternofetal group where if an NIPT is screen negative, ideally we shouldn't try to alter the risk with
Yes.
second trimester soft markers, because
Yes.
and especially now with the CP cyst and pelviectasis, CP cyst as such is not a great marker for Down syndrome. It's more of a marker for trisomy 18. Pelviectasis, definitely. But so in this kind of a scenario, we don't alter, we don't try to readjust the risk if an NIPT is screen negative.
Right, right. I think, sir, very important point here. And if we read the SMFM guidelines, it says that if the NIPT is normal, then these minor soft markers should not be reported. So I think that is something which is very important. The other markers like ventriculomegaly, echogenic bowel, all of them, they have other reasons. So we should look for the other reasons and not just, the aneuploidy part should be laid to rest. So I think that is, thank you, sir, for pointing that out.
Except anossified nasal bone, which
Yes.
actually is something which in my practice, that is something which I would be a little worried about. Otherwise, not with the other soft markers.
Right, absolutely. So, Khurana sir, this is the question which says 40-year-old primary NIPT ton result is showing XXX. What will you do?
Yeah. So not an unusual situation. If you do enough NIPTs, you will find some sex chromosomal abnormalities. This means that there is this kind of a DNA floating around in maternal circulation. It could come from the fetus or it could come from the placenta, because you have something called mosaicism, and the fetus may be completely normal or they could be abnormal. The XXX is not such a bad prognosis, so you can explain the possibilities and let the patient decide. In general, I encourage invasive testing for the sex chromosome abnormalities, because our experience with these over the last 40 years has been that sex chromosomal abnormalities are associated with considerably distressing personality disorders, and therefore all information should be made available to the patient. But of course, whether they want invasive testing or not is their choice.
Right.
Sir, if I can just, anytime anything on paper comes as screen positive, it's very difficult not to go ahead for a definitive testing. Very difficult.
True.
Right. So I think like what both of you are saying is very correct, that anything which is screen positive, because this is a screening test, it needs to be confirmed by a diagnostic testing, which is amniocentesis, and any definitive decision like a termination of pregnancy should not be based on a screen positive test. I think that is something. So if this lady goes ahead and says, I want to terminate a pregnancy based on XXX report, that should not be encouraged, and we must encourage a definitive testing. The next question is, NIPT shows trisomy 18 and a normal ultrasound. Now, this is the other angle to the same question, that there is a positive test, would you do an invasive testing? So Dr. Bimal, would you do an invasive testing?
I would. That's what I said.
Yeah.
Any screening test, I think that is something which comes as a pre-counseling also, that when we do any screening test, and if it turns screen positive, you just have to, maybe the ultrasound appears normal. It could, it also depends on, because we also know that, yes, even with the best done ultrasound, there could still be something which could be missed. Maybe a small VSD, maybe something. So I would still, if it's screen positive, I would like to go ahead and rule that out, definitely. What's your opinion, sir?
I fully agree with you that anything that is positive on a screen needs further evaluation, and the patient has the choice on what they need to do further. I like to encourage invasive testing in this situation.
Sir, I would like to ask the next question from you, Dr. Khurana, sir. And this question is, many labs are doing genetic and biochemical tests. Are they all reliable?
Of course not. I mean, that's humanity, no? There's ordinary, there's superb, and then there's some good ones which become bad. And so we know that ethics is not of the highest order in our part of the world. We have very little work ethic, we have very little personal ethic, and we also have this pressure. Oh, over there it is available for 350 rupees, over here it's 3,500, must be making money. These doctors are all rubbish. But that's not true. We do know that there is outmoded technology sitting out there. We do know that one of the most commonly used technologies, which is PRISCA 2 for first trimester screening, is not available anywhere in the West because it is completely illegal, because it doesn't apply and has not passed any of the rules. PRISCA 5 is okay under very controlled situations, but other platforms such as Roche and Brahms and Cryptor, which are the ones that are approved of by the Fetal Medicine Foundation, are the ones that you have to rely on. And in this business of pricing coming down for the sake of the patient, we really messed up the industry big time. But we must understand that many labs are not reliable. The other thing that you must understand is that beta HCG is thermolabile. So if you leave a sample of maternal blood lying on the table for more than 3 hours, the free beta HCG would go high, higher, highest. And therefore, we all start having fun with our invasives, depending on where we are living from the month of March onwards. Suddenly from March onwards, we're doing amnio, CVS. It's because we don't separate the serum out and then make sure that the HCG escapes into the serum. So that is something, again, that you have to be very careful of in the time to transport, and where the serum is extracted right there at source, or whether it's just left in the bottle until the bottle reaches all the way to Timbuktu. So that is where we stand. I noticed that Aparna has lost her connection, so I'll go on to, there you are. Aparna, you're back again with us. Wonderful. So what I had mentioned was that many labs are not reliable. You have to know which ones.
Yes,
and then
sir.
there's this question about NIPT, all chromosomes, or basic. Again, that story of the price. Let's face it, the reliability is for trisomy 21. NIPT, as we know it today, is for trisomy 21. Trisomy 13, some platforms good, some platforms ordinary. Trisomy 18, most platform good, many ordinary. Sex chromosomes, usually mosaics. When it comes to the rare autosomal trisomies, which is the others apart from the 13, 18, 21, we know that Anthony Borrell from the great country of Spain likes us to do all of them because they seem to give an incremental yield for other situations. The other thing is that our patients love the fact that they're getting something for free. But from a scientific point of view, the world is not yet ready for the rare autosomal trisomies. They create more chaos than contribute to a particular situation. And therefore, I'm not in favor of those. When it comes to our other ones, which is the micro deletions, etc., syndromes, we do understand that detection rates are 60%, 70%, not so nice. DiGeorge's, yes, but then DiGeorge's is not a disease that you'll kill anybody for. I mean, for heaven's sake, the people with DiGeorge's who walk all around and lead very successful lives. And therefore, microdeletions certainly not to be included in an NIPT. Rats, I'm not in favor of, but some people are. But the common autosomal trisomies for sure, and the sex chromosomal anomalies for sure to be reported.
Right, sir. So thank you, sir. I think very nicely elaborated on that point. Following this, there is one question on please tell on binder syndrome, but I don't know if we should take this question here because that is
Yes.
a little away from the aneuploidy. We can have like, you know, we do have as FMF, you can go to the website. I think there's been a whole, you know, you can listen to one series on binders. It's a very interesting one and I really love that part. So I would suggest you visit the FMF website. There's a question on 2 minor soft markers on level 2. Direct invasive or can offer NIPT. Dr. Bimal, what would you do? I think we would see what the minor soft marker is.
Which ones are the ones which that's important, you know.
Yeah.
And then you do the mathematics, look at the first trimester screening, what was the screen result, and then you can modify the risk after you've got a combined likelihood ratio of those 2 markers.
Yes, right. So essentially what Dr. Khurana also mentioned in his talk is about the meta-analysis by the Akata Clears. We should always have that on our systems and, you know, go back and refer to it. Yes. So there is another question is that if there is first child of Downs and there are 2 unexplained abortion of 2 months, is there a role of parental KT to rule out a translocation Downs? So, Dr. Khurana, would you like to take this question? I think anyway, right. Would you like to take this question?
Yes, I just wish I had a geneticist on board to sort
Right.
this out. But I don't see anyone in our crowd today. But to answer that question, let's face it, there is this Down syndrome. There are these two miscarriages, and therefore we need an answer. Now the question is, do I do a parental karyotype? It's very rare.
We have the karyotype of the previous Down syndrome baby. We can definitely know if it's actually a translocation down or if it's a non-disjunction down. And then accordingly we decide. So basically we need the baby is Downs, just do a karyotype of that baby and take it forward from there. If that baby is a non-disjunction down, then anyway it's a one-off Downs, right? So in that situation, the other 2 are unexplained miscarriages. But if that's a translocation down, then it's a possibility that these 2 recurrent abortions are also related to that possibility and do a parental KT. So I think that's how you can go about it. Then of course you need to take help of your geneticist friends. But that's a logical way of thinking about it. So we can go to the next question is there any other aspect of why NIPT screen is positive with T18? Can a repeat screen not required in false positive NIPT cases? You cannot know it's false positive unless you do a diagnostic test. I think false positive NIPT, sir, would you like to take this question? I think false positive NIPT is really risky.
Yes.
And what we would do is let's not waste time. Let's not create any confusion. So I think this has to be very clear. If it's NIPT is positive, go for a diagnostic test. There are limited conditions where NIPT is false positive, right? That could be because of maternal malignancy, maternal mosaicism, right? So all of those reasons can happen, placental mosaicism, all of those situations for whatever reason. If your NIPT is positive, kindly go for a diagnostic testing. So I don't think we must, the only reason why you would repeat an NIPT is when NIPT is inconclusive. However, even in that, 2016 ACMG guidelines and a lot of other reasons do tell us that there has to be a real reason why you're going for a repeat NIPT. If you have any ultrasound feature which is suggestive, then don't repeat NIPT, just go for a diagnostic testing. So a repeat NIPT has to be a very, very strong reason where you repeat NIPT. If you have any confusion in NIPT, if NIPT is positive, go for a diagnostic testing.
I think the only indication would be a low fetal fraction, and then you want to wait for 2 more weeks and then go ahead and do it. Otherwise, if it has given a result, it has given a result. Just go for a confirmation after that.
Right. I think very, very good. And sir, I think we all agree now that even a low fetal fraction now, if they are reporting a test, we don't call it a low fetal fraction. If they're able to report it, so it's just inconclusive. Even fetal fraction now, we are not saying even less than 4%, 2%, they're reporting, we are reading, we are seeing. So I think now let's not repeat an NIPT for a positive or an inconclusive unless we have a very strong reason to repeat. I think the next question is trace. Some labs use a trace software. I am not aware of it. Dr. Khurana, Dr. Sani, are we aware of it?
There are several brands, but there is nothing that will tell anybody whether they are FMS certified. You can only trace a person's name and nothing else. And besides, you have to renew yourselves every now and then. So if you're not renewing yourself every year, the poor trace gets pretty much lost. So, so there is no software that makes you know whether you have somebody there or not, but everybody who is approved is on the FMF website anyway.
Right. And in the selection of invasive testing for T21, which one or a combination should be opted for? I think we've talked about this. Like we are all waiters. We offer the, now I love this, sir. We will offer them the menu.
Yes, completely.
I think this is something that at least, India is like not one India. It's a multiple combination of multiple states and, levels of affluence. But I think it's important that the people are informed that, if you offer dual test, if you offer a combined first trimester screening, your detection rate is 85%. If you offer NIPT, your detection rate is 99%. So it's important that you offer the test, you tell them the detection rate, you tell them the cost. So I think that's important. A cafeteria approach. Till now, I was talking about cafeteria for family planning. Now it's a cafeteria approach for screening, but it's an important message that has to go across. So thank you, sir, for putting it that way. But yes, it's important. I think T18 has come with all anomalies normal. I think this question is coming for the second time. T18 has come in NIPT, then we have to confirm on, I would say confirm this on diagnostic testing. And fetal fraction, I think we discussed that there is no minimum now. If it is reporting, we take the report. So I think that is all for now. And back to Dr. Rima.
Thank you, Dr. Aparna, for taking those questions brilliantly. And I think we've had a wonderful session. I would like to thank Dr. Olak for being with us and giving us an insight into how compassionate these babies are, and termination is not the solution. Parents make the final choice. We thank our mentor emeritus, Dr. Khurana, for always guiding us. Dr. Bimal Sahani, Dr. Aparna for taking on the questions. Vishalji for always organizing things so well. Conference International, and of course, wonderful audience who've been with us for so long to go through this entire session. Thank you, everybody.
Thank you. Good night. Thank you, Rima.
Very well
Thank
done.
you, Dr. Rima.
Thank you.
Thank you. Good night.
Good night, sir. Good night.
Thank you.